Very good evening. Thank you for the invitation for me to give a talk at this lovely gathering, and respected chairpersons and all my dear friends. The future of luteal phase support is the topic for today. I bring greetings from the University of Manipal from Karnataka State, India. I would take you through what we know, physiology, luteal phase support, why, how and when, standard versus intensive support, fresh transfer of embryos, frozen transfer embryos, and individualized luteal phase support, and finally, the role of support in IUI and natural conception. We all know it's a phase between ovulation and the next menstruation. It is deficient in patients who undergo ovarian stimulation for IVF, that's for sure. The luteal phase support, administration of pharmacological agents aimed at supporting implantation to enhance probability of pregnancy with successful outcome. When we know corpus luteum produces is not only progesterone, it also produces estrogen in a small way. So we know that the corpus luteum, basically the hormonal activity controlled by pulsatile production of LH by anterior pituitary, 3-hourly stimulation of the corpus luteum. The mid-luteal phase is a daily production of progesterone of 25 milligram for 24 hours. And estrogen, estradiol, is also being produced by the corpus luteum in a very small way, but both are needed, 0.05 to 0.5 milligram in 24 hours. So when you look at the hyperstimulated cycle as shown in the first arc there, inability to maintain normal secretory endometrium to allow normal embryo implantation and growth. When you compare the normal cycle, hyperstimulated cycle has a short luteal phase. That means there is not much of progesterone there. So when you stimulate the ovaries for an IVF cycle, there are supraphysiological levels of steroids, which basically has a negative action on the hypothalamus and pituitary axis. It inhibits luteinizing hormone release and thereby causing luteal phase defect. The loss of pulsatile release of LH from pituitary gland due to downregulation of LH receptors is basically gets disrupted because of agonist or antagonist protocol. Excessive levels of estrogen, the replacement of LH surge by the trigger of HCG itself. The corpus luteal dysfunction has been clearly established in assisted reproductive technology. The agonist protocol, what we have a long protocol, definitely has a deep pituitary suppression, deficient LH signaling in the forthcoming luteal phase. An antagonist cycle basically has once again corpus luteal dysfunction, and moreover when we pick up the oocyte or the oocyte pickup, lot of granulosa cells are being removed and they do not have corpus luteum there. So controlled ovarian stimulation and HCG, supraphysiological sex steroid production, suppression of endogenous LH and corpus luteal dysfunction. If you look at the red one, it's a natural cycle. The green one is cycle with GnRH analog. Look at the blue one. Antagonist curve is very fast diminishing progesterone there. So if you look at the red one again there, the left one, the GnRH analog, if you give as a trigger, it is a LH surge after GnRH agonist triggering versus natural cycle. There will be a lot of corpus luteal deficiency in them. Hence, if you give GnRH analog instead of HCG, there is bound to be huge amount of deficiency. Some of us don't even transfer the embryos. Some of us do, but intense progesterone support. So the role of progesterone seems to be the secretory transformation and desvisualization as mentioned earlier. But more important is immunomodulation. Regulation of the blood flow there, and local vasodilation, and of course uterine muscular relaxation, the action of progesterone. So we know that recurrent pregnancy losses will need progesterone, all IVF cycles will need progesterone, and of course if you're using gonadotropins you have to give. Most of you are giving unnecessary progesterone in a clomiphene induced cycle or a letrozole, you don't have to give. Just for induction with tablets, clomiphene and letrozole, there is no need to give progesterone support because you're going to close the implantation window unnecessarily. But if you're using gonadotropins for a stimulation of maybe for IUI and things like that, you have to give, because when you give clomiphene and letrozole, it acts on the hypothalamus, anti-estrogenic effect. The gonadotropins acts directly on the ovaries, so you have to give support when you're using gonadotropins. Definitely, neoangiogenesis is important in the luteal phase, because corpus luteal deficiency seems to be the problem in getting pregnancies. So the progesterone is the important issue there. We can also give a little bit of GnRH analog in the luteal phase. You can give HCG, but it's not popular because of ovarian hyperstimulation syndrome. And of course, research, LH says, only Eschre says 2019 is at the moment is still under the research. Now, we use natural micronized progesterone. You can either give intramuscularly, or you can give vaginal gel, or you can give the tablets. We give 200 milligram 3 times a day. The micronized progesterone can be used, and of course subcutaneous injection can also be given at the 25 to 100 milligram per day. But oral dydrogesterone seems to be another introduction in the last few years. We give about 20 to 40 milligram per day. It's not 10 milligram. We give 20 milligram twice a day after embryo transfer, but we don't give any more transdermal, because if you give transdermal progesterone, the dose matching with corpus luteum production is several orders larger than the estradiol. It requires too large a skin system for practical application, and skin is basically rich in 5-alpha reductase, which inactivates progesterone. Hence, we don't give any more transdermal. Intramuscular, everybody knows, seems to be the old traditional injections, but it's oil based, and the disadvantage is terribly painful, yet the patients will take because they want pregnancy somehow. But inflammation, sterile abscesses, and of course non-compliance. Some people get some kind of a breathlessness after that intramuscular, because it has been told to be eosinophilic pneumonia, but is rare, but can also be occasionally life-threatening. Subcutaneous is basically cyclodextrin encapsulation. The newer modality, dose is small, 25 milligram per day. I said how the corpus luteum produces 25 milligram per day. So that maybe are just replacing the same. Better bioavailability and lower dose than intramuscular, more comfortable, and of course vaginal progesterone seems to be the most popular with all of us, because of first uterine pass effect, minimal side effects, rapid absorption, and disadvantages are also there. Many people have irritation, they do not want to use it sometimes, and if you have such a symptoms, there can some discharge and bleeding can occur, and some of them don't want to put anything at the vagina there. So vaginal versus intramuscular progesterone seems to be a little bit of comparison. When we put intramuscular, the serum progesterone is 7 times higher. But vaginal progesterone, endometrial concentration is 8 times higher. So the value of blood levels of progesterone, I don't think it matters, because intramuscular gets into the blood and not much into the uterus. But when you give vaginally, it gets into the uterus as well. The fertility sterility ASRM clearly said, luteal phase support for frozen embryo transfer. Does route of progesterone administration make any difference? 300 patients were studied, 500 FET cycles. Overall, cumulative pregnancy rate was 34% per cycle, with no difference in pregnancy rates in those that received intramuscular or vaginal progesterone. Another report, mini report of 2021, beyond the uterine first pass, optimizing programmed frozen embryo plantation transfers, a mini review was done. It has been found that the vaginal progesterone short half-life of 6 to 8 hours, variable absorption, and limited uterine first pass metabolism leads to supraphysiological serum levels. 50% of intramuscular dose is eliminated in 24 hours, 75% in 48 hours, 87% in 72 hours, but helps in maintaining the value there. However, subcutaneous progesterone, the half-life for 17 hours, may require more frequent injections, but may be more convenient. So if you look at all these vaginal capsule, gel, intramuscular, subcutaneously, everything has its own advantages and disadvantages. You choose individualized method to select for the patient as to what and when to give. However, ESHRE in 2019 clearly said progesterone is recommended definitely for luteal phase support, a strong evidence. Any of the previously mentioned administration routes, non-oral, for natural progesterone as luteal phase support can be used, and dydrogesterone is probably recommended for luteal phase support. The special features are high oral bioavailability, but there can be intrahepatic cholestasis. I had few patients, they come with itching, that's a little bit of not comfortable, but very small number. However, no androgenic, no glucocorticoid, and no mineralocorticoid activity, but we know that reduces cytotoxicity of the natural killer cells by blocking degranulation and shift the dominance from Th1 to Th2 cells. But there are side effects like any other medicine, so many are there, but they are very, very small in number. Lotus 1 trial established non-inferiority of oral dydrogesterone versus micronized vaginal progesterone in 2017 publication. The last line should be read. Lotus 1 demonstrated that oral dydrogesterone is efficacious as much as micronized progesterone in a fresh cycle. Once again, Lotus 2 trial, oral dydrogesterone is a viable alternative in 2018 by Greisinger. The last line to be read again. Lotus 2 demonstrated that oral dydrogesterone is as effective as micronized progesterone even in a fresh cycle. HCG is not recommended because there is no improved benefit over progesterone and definitely increasing incidence of ovarian hyperstimulation syndrome. So GnRH analog, there are many by basically single dose of GnRH agonists on the day 6 after oocyte or embryo transfer may be tried but not proved. Multiple regimes for sure is not recommended. 2019 ESHRE said GnRH agonist as a bolus in addition to progesterone for luteal phase support in HCG triggered cycles can only be used in the context of clinical trial, research only. Repeated, however, is the same. But interestingly, comparison of pregnancy rates and antagonist cycle after luteal phase with agonist versus progesterone, a prospective randomized study by et al. Have said 127 cycles studied. The last line, GnRH analog was associated with a higher pregnancy rates, odds ratio of 3.4, 95% confidence interval, and of course compared to vaginal progesterone. Another study by Chang et al. Have clearly said retrospective study of 300 patients, and again, but they said ongoing beneficial effects on ongoing pregnancy rate and live birth were also different. Addition of estrogen is not clear because endogenously estrogen is an enemy produced a little bit. Meta-analysis is argued against this practice as being not very favorable, and of course it's not recommended. As per ESHRE guidelines, the timing when to start progesterone, the starting of progesterone for luteal phase support should be in the window between the evening of oocyte pickup and 3 days post retrieval. So it doesn't matter if it starts on the day of oocyte pickup or the next day, it doesn't really matter. Progesterone for luteal support should be administered at least until the day of pregnancy test. How long to give was a big question mark. Premature timing of progesterone luteal phase support. Initiation did not negatively impact live birth rate. That means you can give any time. So the luteal phase, how much to give? In India, I'm sure we're giving up to at least 10 weeks of pregnancy. I don't think anybody stops. I'm not very sure. The Europeans and Americans say stop it the day of the HCG report, but we know a little worried about when to stop. So I give up to 7 to 8 or 10 weeks of pregnancy, but most of them, short versus extended progesterone supplementation for luteal phase support, a systematic review and a meta-analysis by Marian et al. There was no significant difference in live birth rate between the patients who discontinued progesterone support at the time of pregnancy test and those who continued little longer. Our patients, when I tell them, they said little worried about it. We have no study on that in India. However, fresh and frozen embryo transfer, there is no benefit of HCG or estradiol to progesterone, An agonist may have a small role on the day 6 of embryo transfer. One dose, of course, everything seems to be arguable. Luteal phase support for women trying to conceive by intrauterine insemination or a natural intercourse. Vaginal progesterone may increase clinical pregnancy rate. However, its effect on miscarriage is uncertain. Uncertain for sure is intramuscular progesterone, etc. But however, neither oral progesterone nor any other medication appears to be associated with any improvement of pregnancy outcome. As I said, a clomiphene and letrozole induced cycle, there is no need to give. You give for gonadotropins only. So finally, which route of progesterone is most effective? Cochrane review found 25 studies comparing different modes of progesterone. No significant difference in terms of live birth, ongoing pregnancy. There is no convincing evidence that one route of progesterone is more effective than the other, although more and better designed trials are needed for sure. We must look at pharmacology of different routes and patient preference. The quality of evidence range from low to very low. To conclude my presentation, we do not know it all with regard to luteal phase support. However, some important clinical questions can be answered with a reasonable degree of certainty. Overall, progesterone appears to equally effective HCG compared to HCG, but we know OHSS is high, and different routes of progesterone have similar efficacy. More patients' preference studies are needed as to the route and preparation of progesterone. More work is needed on luteal phase monitoring, the aim of personalizing luteal support. So what's the future? It's for you to decide. The future of progesterone support has to be argued quite pretty well, and discussions should go on as always. We find scientific evidence is most important. Thank you once again for your invitation and for the requesting me to give a talk. Thank you so much.
Thank you, Dr. Pratap Kumar. That was a very insightful talk. And I think we all know that individualizing luteal support is also now coming in, and you touched upon it. I think that's really important, doing progesterone levels at different, before starting, whether you want to add, and all of us in this audience are using multiple routes in a patient. That is the practical thing that we are doing in our practices. And I'm glad you touched upon it, that there is no Cochrane review, or there's no firm evidence to say that do this or do that. And even the World Survey actually says that all the physicians are actually, I don't know if anybody on the panel would like to comment on that.
In fact, there has been a Midron study in 2021 that compared only vaginal progesterone and vaginal progesterone with dydrogesterone in frozen embryo transfers. And the pregnancy rates were similar, but the biochemical rate in the one taking dydrogesterone was significantly less. So this was the first study that we are all very skeptical of multiple progesterone use, but this was the first documented study that said that we may use it and it may have a benefit. And that we've started doing that, and though the data is yet to come out.
Thank you, Dr. Pratap Kumar. Thank you for that really enlightening talk.
I have a question. During the luteal phase support, we are using progesterone for the luteal phase support. And in a frozen embryo transfer, we are using estrogen for the growth of endometrium. And how long should we continue this estrogen?
Yeah, that's what I said. The role of estrogen is very limited. And if at all you give it till the beta HCG is positive, then you need not continue. But all the literature doesn't say estrogen has to be added along with progesterone.
So we are giving estrogen for endometrial preparation. And after embryo transfer, should we stop estrogen?
No, it's like that, because first of all, there's not much of place at all. But if you give, you can continue with no harm in pregnancy. You can give up to 10 weeks of pregnancy. But I don't continue, because I just stop, because the exact action on the pregnancy is not well understood. Bashini, you want
So
to say?
we stop it practically at between 8 weeks, 7 to 8 weeks. I mean, I continue estrogen till then. Once
Yes,
the
there
beta
is a
HCG
recent
is
paper
positive.
actually, we suggest that we should discontinue after 8 weeks.
Yeah, 8 weeks we stop the
Yes.
estrogen, and between 10 to 12 weeks the progesterone is stopped.
Yes, yes.
Thank you, Dr. Pratap, for your wonderful talk. You have covered the whole aspect of the luteal support. I just want to say a word about it. Years together means more than a decade when I started, and the Crinon gel and the other gel, vaginal gel came. So we started that, but the patients were not comfortable because there was so much of vaginal discharge. And then the Dufestone came. So the dydrogesterone was given orally with the intramuscular progesterone. I am very fond of that because I cannot rely one drug for the luteal support, because my patients are of the, for years I worked in a government hospital, and my patients were not that well to do to spend so much of money and without pregnancy. So always I have given the two drugs that it has to be covered properly, as now the studies has come that Dufestone is not giving proper finding, proper progesterone level, and something should be added for that. So of course intramuscular is a very painful. So now with the vaginal progesterone and dydrogesterone works very well, I must tell you. This is my experience.
So that's a very interesting finding, ma'am. But over the years, intramuscular progesterone with its huge side effect, I think one of the things that patients avoid IVF is because of the pain of intramuscular progesterone. And if we are able to reduce that, I think it will be a great benefit to our patients. And I'm sure we have each our experience, but we have seen vaginal progesterone with oral dydrogesterone gives equally effective results. However, in those women where there is premature spotting, where the bleeding comes earlier, we have to transfer in an agonist trigger cycle, and in some repeated failures, we are administering intramuscular progesterone. But I'm sure you'd agree that the effort should be to move away from that.
I think it almost seems like every decade the approach changes. You know, when it's we understood that we needed to give a luteal phase support early on, it was HCG first, and we had problems with hyperstimulation and OHSS and that type of a thing. Then the intramuscular. Intramuscular was painful, therefore was almost not used in Europe. And it took about a whole decade before Europe found out that if you used only vaginal, a good percentage of them were not getting adequate amount of support. Whereas it was absolutely, intramuscular was banned in Europe for that period of time. And then it became IM, and then now the current thing is the oral one. As far as the patient is concerned, it's probably the best possible way that you can give it. And I think it's fairly, the Lotus studies, I think part of it was done in India as well with some of our experts, and it's been fairly comparable to it. And I don't really mix up too many things. I stick to one thing and do it. And I don't think I've had any problems with using dydrogesterone alone.
It was a very nice talk, Dr. Kumar. You did highlight a lot of things. There is still a lot to learn from properly based research, and we all can pull in our experiences and get the best possible solution for the patient. And I think that's all I would like to say for this particular session. Thank you very much. And I thank my colleagues sitting as panelists. Thank you.